Okay, now that we've talked about the differences between the benign and the malignant ones, let's see the epidemiology of neoplasm worldwide. Now, the incidence vary depending on sex and age. So, depending on what type of neoplasm it is, it has different incidence in different sex. That means sometimes male get different types of neoplasm compared to females, and older people tends to get different type of cancers or neoplasms compared to younger generation. And geographic environment also plays a role. For example, there's a high incidence of stomach carcinoma in Japan, while in breast carcinoma in US and liver carcinoma in Africa. So this is because of the environment. Japan, they think it's because of their tendency to eat raw seafood, which is why they have a lot of stomach carcinoma there. But they have very good screening system in Japan. Everyone there will have undergone endoscopy at some point of their life because they check whether there's any growth. If there's any abnormality of any sort that they see during endoscopy, they will take a sample and then they will look under the slide. If there's abnormal, then they will call in the person to do further investigation. While liver cancer in Africa is due to because of the high rate of hepatitis B and C in Africa, which gives them a higher predisposition towards developing liver carcinoma, which is why it's higher in that continent. Now, heredity. Some cancer are inherited, but most cancers are sporadic. That means it just occurs randomly. We don't know why some people get it and why some people don't. But the inherited ones tend to be the breast cancer type, which is BRCA1 and BRCA2. If you have this gene, you have a much higher percentage of having breast cancer compared to the general population. For example, the most famous one I would say Angelina Jolie. She's definitely not my favorite actress, but she's a good example because her mother and her aunt died from breast cancer, and she also has the gene, and she actually opted for preventive mastectomy. She did a double mastectomy and did breast reconstruction. So basically, she removed her breast tissue and rebuilt it with plastic surgery, new breast, because she's worried about the risk of her getting the breast cancer is high because of her gene and her family history. Okay, I'm not saying that in Malaysia we offer this, but it's an option for people who is in that kind of situation. Okay. Right, so this is the estimated cancer incident. As you can see, the incident or kejadian, maknanya people yang have it. You see the highest in male tends to be prostate, 33%, and it occurs usually in older gentlemen, like in 70 something. And prostate cancer is very slow growing. Sometimes the patient actually die from something else before the prostate cancer actually kills them. Okay, because people yang kena ni dah 70 plus, they have other illnesses, and prostate cancer is so slow growing that they die from something else. While in women, you see 30% is breast cancer. Okay, that's the most common one, incidence. But you see the death, tapi yang kills both male and female sama is what? Lung cancer. Because lung cancer tends to be diagnosed very late, and if you already have metastasis, it usually takes 3 to 4 months je, your lifespan, and then the patient would have died, which is why it has a much higher rate of death. So you see the rest. So for men is prostate, lung, colon. For women is breast, lung, also colon. But the ones that kills you, lung, prostate, then colon, and then here is lung, breast, then colon. Now, the new ones might be different, but I would say it's about the same. Lung cancer is still one of the most common cause of death in a carcinoma group. Okay? Which is why people keep telling you don't smoke. That's the reason. Right? Now, what is the etiology of carcinoma or neoplasm? There's 3 classes of carcinogenic agents. It can either one can affect the person, or maybe 2, maybe 3. So one is chemical. This is direct chemical agent, which is alkylating agents, or indirect, for example in fossil fuel in cigarette. So alkylating agents ni macam benda yang you memang tahu carcinogenic, you directly sentuh benda tu, or indirectly by smoking cigarette. After a few years, you have accumulated so many of these chemical abnormalities due to this chemical material that you smoke. Second is radiation, so either from UV, from X-ray, or the worst one, which is nuclear, like in Hiroshima and Nagasaki. And the third one is from microbial, right? Viral microbial. Remember when we talked earlier, for Epstein-Barr virus, it produces DNA that can actually cause cancer, or HPV, which is an RNA type. So for example, a T-cell lymphoma. So all this can actually cause or create predisposition towards cancer from virus or microbes. Now, these are the different types of chemical carcinogens. So you see alkylating agents, propyl lactone, this is used in cleaning agents. Anti-cancer drugs can also cause cancer. Now, procyclics, these are benzene, dibenzene, these are all found in cigarettes. In natural plant, like betel nuts, you know sirih? Orang makan sirih sekarang dah tak ramai orang makan lah, but they used to eat a lot before this. So sirih can actually cause oral cancer. Now there's one here, nitrosamine. I think I talked to you guys kan about this, that nitrosamine is a dye. It's a red colour dye that people put on beef to make it look nice, to sell it more of beef. So nampak merah tu nampak macam menariknya daging ni. So that's what they put in. But they discovered that once you eat the beef that has this nitrosamine, then your acid, your hydrochloric acid in your stomach actually change nitrosamine into something that is carcinogenic and can cause stomach cancer. So now it's banned. You're not allowed to use anymore nitrosamine. Okay. So this is an example of a survivor from Hiroshima Nagasaki nuclear bomb. He survived the direct impact. Well, not survived lah actually, because he has a lot of severe morbidity, but he didn't die from it. He actually died from a cancer, leukemia, from the side effect of the nuclear bomb. Okay. There's also occupational cancers. These are where you get cancers from where you work. The most famous one being asbestos, right? This is what we use to actually insulate the house. In a lot of developed countries, they actually ban, but Malaysia still lagi pakai. It can actually cause mesothelioma. This is a carcinoma of your pleural lining of the lung. So it's, I suppose, considered under lung cancer. Then you have benzene, used in a lot of industry, including printing. Then you can get leukemia and Hodgkin lymphoma. People who work in coal mines, right? Coal mines, they can actually get a lot of the lung cancer as well from chromium compounds. So these are the different type of things that actually can cause carcinoma due to their carcinogenic effect. Okay. Right. Next is we talk about how do the patient or the body, the human body, defend itself against tumor. One is with that we have a tumor antigen. So when a tumor grows, it produces the antigen that elicit immune response, where your TSA or TAA or TAA, this is not the Liverpool player, kalau you guys follow football. So this TSA or TAA, these two will then attack the antigen. Because they recognize the antigen of the tumor, it will then attack the tumor and destroy the tumor. So the tumor specific antigen, right, will be attacked. This is product from mutated oncogenes and tumor suppressor genes, and product of other over-mutated genes. So it's overexpressed. Maknanya instead of dia produce satu, dia produce more, and that actually can cause this antigen from also from oncogenic virus. So that means virus that can cause cancer also can cause the body to produce this tumor antigen. So once you produce this tumor antigen, your body will recognize it and then will kill that tumor or try to destroy the tumor. The problem is when the tumor grows so fast, your body cannot keep up. That's when you have the problem. If the cycle is balanced in homeostasis, then the more you produce the tumor, then your body actually kills it. We actually have mutated genes like every single second or every single minute maybe, because of effect from environmental pollutant. But your body will then try to get rid of it by destroying this abnormal gene or abnormal cell. You also have what we call anti-tumor effector mechanism. This is a cell-mediated system. It involves cytotoxic T cells and natural killer cells, macrophage, and the humoral mechanism. All this is part of your immune system. It will then mediate and kill the tumor. Now, that's what we call anti-tumor mechanism. Again, if your mechanism is slower than the growth of the tumor, then that's a problem. That means you cannot cope with the growth and the impending effect. Third is what we call immune surveillance. You have lost and reduced expression of MCH and immunosuppressant. Now, this one I will explain when we talk about immunity lecture, which is lecture 6. I'll probably do that sometime next week, and then I'll explain this more at that time. Okay. Because if I explain now, you wouldn't understand because we haven't had that lecture. Right, next is clinical aspect of neoplasia, or what the patient actually complain of when they have cancer. Now, the effects may be depending on the location. Like, for example, if the tumor is in the brain, they will complain of headache. If tumor is in the abdomen, they complain of stomach ache, right? Different. And it also depends on whether it affects hormonal activity. For example, if there's a growth in the pituitary, which we call pituitary adenoma, and it produces hormone, the complaints that the patient will actually say is due to the hormonal activity. For example, if it's thyroid hormone, it affects thyroid hormone, then there's too much thyroxine in the body, the patient will then complain of being too hot all the time, sweating, shivering, their hands will be shaking, they're hungry all the time. So this is increased metabolism activity due to high thyroxine, due to a tumor in the pituitary adenoma. So they will complain of the hormonal activity effect. Sometimes it will cause bleeding. For example, like we said earlier, the leiomyosarcoma, it's a fast-growing tumor, then you have necrosis and bleeding in the center. So that can cause pain as well. So you can see the difference. This is tumor in the brain. This is a cerebellar tumor because that's the front, that's the occipital, your cerebellum, right? So this is a cerebellar tumor. It's not that big. It's about maybe, what, that size maybe, right? As compared to that. This is an abdominal tumor. This is not malignant. This is benign tumor. But you see how big it is? This is almost half of this person. Okay, so it's like, I don't know, 3 kilos, 4 kilos compared to that big. But both, this kills the patient, this the patient survives. So it depends on the space. Okay. And that's a pituitary adenoma. If you look, if you tip this thing like this, it will bulge out like that. But pituitary is not supposed to be like that. It's supposed to be flat. You cannot see the pituitary when you put your skull or your brain like this. But if there's a growth, then it goes above the plate where the pituitary is sitting at, is what we call sella tussica. So it's protruding out. So this is a growth with necrosis and hemorrhage, most likely a malignant one. See the bleeding. Now, who can tell me where is the normal tissue? You guys tell me. You guys ambil screenshot, bulatkan where is the normal tissue. Okay? And you tell me in WhatsApp. Alright, so fourth is where you have what we call cancer cachexia. I'm sure most of you have seen someone with very severe cancer or died from cancer. Do you realize how thin they were at the end of their illness? This is what we call cancer cachexia, or thinness due to cancer. This is because your tumor necrosis factor, or TNF, is produced, a lot of it is produced because of the tumor, and is suppressing the appetite and the patient does not eat. That's one. The second thing is because the cancer is actually taking all the food, nutrient, all the good stuff that you put in the body, is actually given to the cancer. The cancer is using it up, not the person. So which is why they keep losing weight. Also, if they have bleeding, like in the picture before, you have a lot of necrosis in the tumor, the loss of blood, and then that also causes the cachexia. So loss of body fat and protein. So you can see someone who was a bodybuilder can actually go like that, become very, very thin. And this is another example of cachexia. You can see, what is that? Who can tell me what type of cancer that is? Again, you tell me in WhatsApp what type of cancer this is. We talk about this, I think, in the infection lecture. You can see, you can tell if it's abnormal thinning. Some people are naturally thin, but if you look at your own body, right, at your pelvic area, is it that area macam ni ke, concave ke, macam ni? Dekat pelvic area tu. Normal people are like this, dia mengembung ke atas. Tapi when is abnormal or pathological thinness, dia akan jadi scaphoid, what we call scaphoid. Dia hilang all the fat at that area and they become like dark inside. Okay, that's not normal. Not, it's pathological thinness. Maybe people with anorexia will also have that, like pathological thinness. Now, the fifth complaint that the patient might complain of is due to paraneoplastic syndrome. This is where complexes that occur or abnormality that occur is not explained by the tumor, either the tumor itself or the metastasis. Maknanya dia bukan typical one, bukan sakit kepala, bukan sesak nafas, bukan all that. 10 to 15% of patients with cancer will have this. The symptoms are totally different from the cancer itself. For example, squamous cell carcinoma of the lung it tends to produce hypercalcemia, though it's not due to the effect of the tumor itself. When you have hypercalcemia, you will have problems with your muscle movement. So you have like that. Patient complain of their hands like that. They cannot control it. So when you check their blood, you will see they have high calcium. But it's nothing to do with their cancer. Okay. So these are all these are the different type of paraneoplastic syndrome, and what are the cancer that causes it. So you can go through on your own. You don't need to hafal any of this, right? Now, next part is how do you grade and stage. Katalah you have a family member, nauzubillah, but it may happen, like you have a family member or a patient comes to you. Do you think bila you kata kat dia it's a carcinoma or a malignant neoplasm, apa yang first thing dia nak tahu? Will I die? Right? For you to answer whether they will die or not, you need to grade and stage the tumor. What we call grade and stage, okay? Grading is where you estimate how aggressive the malignancy is or how bad is the level of malignancy based on mitosis and differentiation. So if you remember yang difference tadi between benign and malignant, the number one, it's very important. How different is it from the normal cell and how much mitosis is there, you can tell the aggressiveness. So the ones that are fast growing, that means banyak mitosis, grow sangat fast, differentiation is very poor sebab dia sangat laju, we put that as very aggressive. While the well-differentiated ones yang grow not so fast, there's not a lot of mitosis, those we put as less aggressive. So grade 1 stage is the least aggressive, while stage 4 is the anaplastic type of tumor or the severely aggressive. But sometimes even before you grade pun, usually you grade bila lepas surgery ya. Even if you grade from while surgery pun, sometimes during surgery itself you can already tell if it's aggressive or not. Now staging is the other thing that you need to do, grade and stage. Now staging also has 1 to 4, but this is based on the primary lesion, the main tumor itself. Also you look whether it has spread to lymph nodes or not, or whether it has metastasis or not. Like I told you guys earlier, stage 4 means metastasis. No matter how big or small the primary lesion is, if there's metastasis, it's automatic stage 4. If there's no metastasis, then you look at the primary lesion, how big the size and all that. But it's not the same untuk semua. Maknanya different type of cancer have dia punya own protocol. So that's why for oncology it's very difficult, because different cancer you kena belajar different protocol. Different cancer lain lagi, lain pula protocol dia. You nak grade, you nak stage, it's the basic is similar, tapi the details are not. So you have to rujuk balik your protocol, and that's why you kena bila you nak grade or nak confirm metastasis, confirm malignant tumor, you have to have dua specialist countersign, because tumor diagnosis is via cell. Okay, that means you kena tengok bawah slide. Tak ada bawah slide, you cannot 100% confirm. Gold standard is bawah slide. So once you tengok kat slide, you kata, oh, this is malignant. You rasa dia malignant, you list out why, and then the specialist kena cari pula klik dia, so tengok the same slide, and then klik dia pula tengok, okay, is it the same? Do they feel the same? If they think both of them say, yep, this is malignant, then only they countersign. So that means 2% decide whether it's malignant or not. Then baru pergi to the oncologist to decide what to do. Sebab yang tengok slide ni bukan oncologist. Yang tengok slide ni is what we call histopathologist, right? It's unfortunate that because of the COVID ni kita tak dapat pergi hospital melawat, because obviously they orang dah stop all unnecessary essential service sahaja, so we cannot go and see. Kalau you dapat pergi tengok, you will see how diorang actually process the tissue, from tissue to slide, and then from slide to the doctors that actually read it. They're called histopathologists. So diorang different speciality. They will then read the slides and say, okay, this is benign, this is malignant, this is aggressive, this is not aggressive. Diorang decide. Okay, once they want to confirm decide, then they send it to the oncologist, and then the oncologist will read through, and then the oncologist will then decide staging. Staging mana, meds or not meds, and then decide the treatment. Okay, so as with anything in life, kita ni teamwork. There's no such thing as you work in silo. So seorang je buat kerja, no. Kena ada orang yang diagnose, kena ada orang yang go for treatment, kena ada orang yang jadi center, which the oncologist, dia center, dia kumpulkan all the reports and then dia decide. But diagnosis dia depend pada orang lain. Sometimes treatment dia kena refer pada orang lain depending on the type of cancer. So everyone, there has to be teamwork. Just like now, right? Situasi kita sekarang dalam PKP ni, it's teamwork. It's not just frontliner buat kerja. I mean like rakyat pun kena do their part, right? Stay at home. Right, so the last part is the laboratory diagnosis. As I say, you look at the morphology, the shape. So that means you have to do excision biopsy. This is where you actually remove the whole lump. Or you do what we call fine FNAC, which is fine needle aspiration cytology. This is where you masuk a needle, nama pun fine needle, into the lump, and then you remove some cell, usually cell plus liquid, and then you tengok bawah slide. Okay, it's different from the excision biopsy, but excision biopsy tends to be untuk full solid tumor. This one tends to be tumor yang ada air sikit. Sometimes they need to do frozen section. For example, somebody with a very serious tumor that they need to do immediate surgery, and then they take out a bit of the sample, kemudian tu dia orang tunggu dekat dalam OT, dia hantar to the lab, the pathologist dah tunggu standby, dia baca the slide, and then dia kata, okay, this is malignant. Then baru surgeon go in and remove the whole mass with margin, berapa banyak margin. Kalau misalnya dia hantar to the lab, and then histopathologist baca, the doctor, the specialist in charge baca and said that, oh, this is benign. So then they remove, the cara removal will be slightly different. The protocol will be slightly different. So this is certain type of cancer that you're not sure benign or malignant. Sometimes you do this what we call frozen section. But of course, you dah kena bagi tahu awal, so the histopathologist and the lab tech will be standing by while they are doing the surgery actually. And the surgeon tunggu actually in the OT, waiting for the result from the lab. Okay. Next, aside from doing the morphology, that means you tengok bawah slide, you can also do tumor markers, but it's not gold standard. Gold standard is always morphology. So tumor markers, you have quite a few. PSA, which is prostatic specific antigen untuk prostate cancer. CEA, chorionic embryonic antigen for liver cancer. Alpha fetoprotein for stomach cancer. So there's like different enzymes that you can use as tumor markers, but we tend to use this more untuk monitor treatment rather than to diagnose somebody. It's a helpful evidence, but it's not the main evidence or not the gold standard. You can also monitor hormones if the tumor can produce hormone. Now the third type is molecular diagnosis. This is using DNA and molecular to confirm malignancy, prognosis. Sometimes you not detect residual cancer and to find out if it's hereditary. So you need to use this molecular diagnosis if you think that the family members may also be at risk if they have the same gene. Again, if kita pergi tengok lab, if we had the chance to go visit the lab, you guys would have been able to go to the molecular lab and then tengok how they use chromosome analysis to diagnose different disease. Like diseases yang kita tengok, remember last week when we talk about those inherited diseases like Down syndrome, Edwards syndrome, Patau syndrome. Molecular diagnosis helps with that because they can actually see the chromosome, but they also can help in cancer, as in to diagnose the hereditary nature of the particular cancer if there is any. Alright, I think that's it. I think you may have quite a bit of question on this one because it's a totally new thing and it's a very important topic. So if anything, just WhatsApp me. Alright, thank you. Have a nice day.